Aortic stenosis occurs when the aortic valve narrows and it restricts the blood flow from the left ventricle to the aorta. The narrowing is usually caused by leaflet sclerosis, causing thickening and stiffness. In this video, we will go through the epidemiology, risk factors, symptoms, clinical findings, imaging, staging, and treatment. Epidemiology. It's more common in old people. It affects around 2% of those above the age of 65, and it's more common in men. Aortic valve stenosis is usually caused by aortic valve sclerosis, which is way more common. It affects around 25 to 30% of those above the age of 65. Risk factors: a bicuspid aortic valve, which is seen in around 1 to 2% of the population. Instead of 3 cusps, these people have 2 cusps that are usually unequal in size, which causes turbulent blood flow when the blood flows through from the ventricle to the aorta, and the turbulent flow increases the likelihood of calcium deposition and sclerosis of the heart valves. The mechanism is through reduced protective shear stress, with less stimulation of mechanotransduction mechanisms and its transcription factors. This causes a reduction in endothelial nitric oxide synthase. Endothelial cell repair is also reduced. Reduction of these factors increase reactive oxygen species and increases the endothelial permeability to lipoproteins such as LDL into the subendothelial space. Leukocyte adhesion and apoptosis is also stimulated, further increasing the inflammation. So what actually senses that the blood is not laminar but turbulent? We think that it could be mechanosensitive ion channels that open in response to laminar flow for some reason. We also think that the cytoskeleton can signal, and the glycocalyx, which are the carbs that line the luminal side of the endothelium. So we think that these carbs can send signals to the cell. Hyperlipidemia and hypercholesterolemia. LDL, which is the bad guy, goes into the subendothelial space and it gets trapped there in the proteoglycans. Here, the LDL gets oxidized, and the oxidized LDL directly stimulates proliferation of fibromyocytes and fibroblasts, which makes the valve thicker and stiffer. In the same way as in atherosclerosis, foam cells also play a role here. Foam cells are formed when the macrophages phagocyte the oxidized LDL. Cytokines from the foam cells and also other immune cells that are recruited stimulate the transformational change from fibroblasts to myofibroblasts that release cytokines that stimulate matrix remodeling, recruitment of more immune cells, and osteoblastic differentiation, ultimately leading to calcium deposition, making the aortic valve thicker and stiffer. It's both the smooth muscle cell proliferation and the calcium deposition that makes the valve thicker. Smoking. The mechanism is the same as in atherosclerosis. Oxidative stress and inflammation increases VLDL and LDL from catecholamines that release fatty acids in the bloodstream, and thus VLDL and LDL. It also reduces the reverse transport of cholesterol back to the liver. Smoking also causes endothelial dysfunction through several mechanisms. The most important one is from reduced endothelial nitric oxide synthase. Smoking also plays a role in remodeling, increasing the smooth muscle cell proliferation, and extracellular matrix degrading. Hypertension. So the theory is that the hypertension can damage the endothelial cells and thus increase the recruitment of monocytes. We don't really know the mechanism in aortic valve sclerosis, but we know that in big arteries, hypertension can actually stimulate the proliferation of smooth muscle cells. Early symptoms: exertional dyspnea, and this is through reduced cardiac output. Exertional angina, and this is from the heart beating faster when we exercise, and then the heart doesn't have as much time in diastole when the heart actually has time to supply itself with blood. Left ventricular hypertrophy is often seen in aortic valve stenosis too, and this condition commonly presents symptoms of chest pain. Exertional syncope. Exercise causes vasodilation, and when the aortic stenosis can't keep up with the cardiac output, blood pressure drops, and you faint. Exercise can also cause temporary bradycardia. Bradycardia should be avoided in aortic valve stenosis to maintain the cardiac output. We also think that patients with aortic valve stenosis have some degree of baroreceptor dysfunction so that the heart rate and vascular constriction is not increased in response to the exercise. Clinical findings. A weak and delayed pulse can be palpated on the neck. This is called pulsus parvus et tardus. On heart auscultation, you can hear a systolic crescendo-decrescendo murmur, which is increased with squatting and reduced with Valsalva maneuver. When you do a Valsalva maneuver, you reduce the preload to the heart, and aortic valve stenosis is highly dependent on preload. The murmur can also radiate to the carotids. Common ECG findings. You can commonly see left anterior hemiblock or left bundle branch block. A second or third degree AV block is usually seen in severe aortic valve stenosis. This is from calcification and damage to the AV node or bundle of His. Which labs are used for prognosis? NT-proBNP or BNP is correlated with worse prognosis and more symptoms. What imaging is used for screening? A transthoracic echocardiography with Doppler is usually used to screen for aortic valve stenosis. So what findings can you see on the echocardiography? You can see the amount of calcification. You can also see the ventricular strain. You can measure Vmax, which is the peak blood flow velocity from the ventricle to the aorta. The mean transvalvular gradient is calculated. This is the difference in pressure between the ventricle and the aorta. The aortic valve area is measured. This is the maximum size of the hole when the valve is open. Staging. What are the criteria for stage C, severe? A Vmax of at least 4 and a mean pressure gradient of at least 40. A mean pressure gradient of at least 60 indicates a very severe aortic stenosis. What are the criteria for stage B, mild? A Vmax over 2 but less than 3. If it's over 3 but less than 4, it would be a stage B, moderate. Indications for an intervention. A severe aortic stenosis that is symptomatic should always be treated with an intervention. But an intervention is also indicated when you have a severe aortic stenosis and a progressive decrease in ejection fraction, so that it's less than 60% from what you previously had. Another indication is a severe aortic stenosis with a yearly increase of Vmax with over 0.3 meters per second. A very severe aortic stenosis is an indication. The definition of that is a mean transvalvular gradient of at least 60 or a Vmax of at least 5. An NT-proBNP or BNP over 3 times the normal range. And a severe aortic stenosis with heart failure, defined as an ejection fraction less than 50%. So what about the interventions? With cardiothoracic surgery, you can do an aortic valve repair, where you can separate fused valve cusps, reshape or remove tissue, or do an annuloplasty, which is reinforcement of the annulus around the valve with an artificial ring. The second option is to completely remove and replace the aortic valve. The replacement valve can be biological from pig, cow, or human. The biological valves usually require a reoperation within 10 to 20 years, so it's recommended for people above the age of 65. The replacement valve can also be mechanical, which is recommended for people below the age of 60. The problem with this type of valve is that it increases the risk of thrombosis and thromboembolism. If this valve is used, you therefore need to be on warfarin for the rest of your life. For patients above the age of 75 or who are high risk for surgery, TAVI is recommended. Transcatheter aortic valve implantation. It has fewer complications related to surgery. The third intervention you can do is a balloon aortic valvuloplasty, which is widening of the aortic valve with a balloon. This is not a long-term solution, but it can be used for severely symptomatic patients that are waiting for surgery. Medications are used for aortic stenosis to reduce symptoms. Diuretics are used. Statins and beta blockers should be used for comorbid coronary artery disease. ACE inhibitors can usually be used, but you should be careful with a severe aortic valve stenosis since it can cause a severe drop in blood pressure. Nitrates, however, are contraindicated. They reduce preload. Aortic valve stenosis is highly dependent on preload. If preload is reduced, this can cause a severe drop in blood pressure. Thank you for watching. Please like and subscribe. And if you want to revise what we went through in the video, you can download the app in the description. If you want to see more videos like this, you can check out this video. Bye bye.